Thank you again for joining us. I'm Jennifer Brout, and this is a kind of an open conversation about misophonia in childhood. So both Lauren and I will be moderating, and we have here today Diana Calisano, and Dr. Diana Calisano is an audiologist at Empire Hearing and Audiology, and I have the great pleasure of often working together with her. And we will also be having Julia Simner, who may be having some trouble coming on. But just so that you know who she is a professor of neuropsychology and the director of the Multi-Sense Lab at the University of Sussex. You may have seen her before. And the reason hello, there she is. Okay. The reason we put together these panel discussions is really for the audience, for you guys out there, to ask whatever pertinent questions you have about childhood. And I'm just going to open this up by saying that the research on childhood is behind that of adults. And I would love to ask Dr. Simner, why is that? Why is it harder to research children? I think that's important for people to know.
So I think there are two reasons, and they're both very practical. So the first reason is because it's much easier to test adults in many ways, and not only because adults will very much understand instructions of the task and so on, but because adults are out there on the internet, happy to join up for studies and will join databases and have agency to join databases. For children, I don't think they would necessarily know how to join a database, or would probably be more interested in other things. The other reason, I think, is an ethical reason. Whenever we test children, it raises the ethical bar, and it can it brings a lot more considerations, and that can sometimes be off-putting for busy scientists. But I think those are the two key reasons. I think people are very much interested, and I think actually there's a bit of a history in the psychological sciences to think that somehow the adults are the default. You know, we want to find out about misophonia. Well, of course, we'll start with the adults, but you know, you have to look under the surface. You have to, see where all of that came from. So I think those are the real reasons. Unless I've missed any.
Thank you. And along those same lines, Dr. Simner, what can an adult learn from research in childhood? So if I'm, an adult with misophonia, why am I interested in reading about children?
I think it gives some backstory, doesn't it? Sometimes adults are not always good at remembering their first misophonic moment. They might remember misophonia as an adolescent when things started to get really tough. But I think when we look at children, we can learn that the roots of misophonia really are stretching back early. I think the earliest age we've looked at so far with any meaningful data is 7. And everything that you can see in an adult is already there in a 7-year-old misophonic, significantly higher risk of anxiety and depression and those things. And it reminds me of that Quaker proverb, show me the child when they're 5 years old and I'll show you the man. That actually a lot of what we see in adults is already present in children.
Thank you. I'm going to open this up to everyone, but it is a question for Dr. Calisano. As a clinician, what is the most frustrating for you? I know that's a broad question, but I think as an audiologist, you can answer that in a very interesting way, if you don't mind.
Sure. So I think one of the questions that I get very often from patients, or if they're adults or, parents of children who are bringing their children in for help is, of course, what causes this and why there might be so little, everybody looks at this as what is the treatment? What can I do? And so I think that there seems to be somewhat of a concern that there's not maybe the resources that are not available for them, or they don't know where to look. In which case, then of course I'm giving them as many resources as possible. But I think it's a search for etiology. What causes this? Did I cause this in my child? Why is this happening to them, or what was different for them than perhaps my other child who doesn't have misophonia. So I think the why, the etiology, and also what they can do to help this for either their child or for themselves.
Absolutely. So I'm just going to ask Chris's question, which just disappeared. And then I'm going to turn it over to you, Lauren, if that's okay.
Great. That's great. Yes.
Your question, here it is. Might we see a validated misophonia assessment for children soon? I guess, Julia, maybe that is, Dr. Simner, that would be a question for you, or for Lauren, actually.
Yeah, I mean, the answer is yes. It's practically here already. What we have already, at least in Sussex, is we have created, well, first of all, yes, there is a validated scale for adolescents already that's been validated from children aged 10 years and upwards. It's written in the language that would be understood by a 10-year-old. We use lots of psycholinguistic databases to check we were using age-appropriate language, and then we validated it. So it's there for adolescents. What we've also created is a pictorial test for younger children from the age of 6 onwards. And I think I flashed up a screenshot from it. It represents triggers in picture form. And we have this fantastic science illustrator who has a way of making line drawings that can show really quite complex emotions and attitudes. And he created the test for us. The test, we now have the data gathered from it. We have a collaboration with UPenn and also with University of Las Vegas, University of Nevada at Las Vegas, and we have data gathered for it, and we're poised to do the validating for that younger questionnaire. We just need some grant funding to support our postdoctoral researcher who is our statistics whiz. So it is posted online, it can be used, it's probably best, and the feedback is there in a kind of descriptive form, and pretty soon we'll also have the statistics to show the extent to which it can be. And I've seen the data, it is sort of informally validated already. It's just that we need a bit more time to get that published and out there.
Great. So 2 bits of follow-up questions. So Dr. Calasano, when you do have a family come to you and they're seeking answers to their questions, they don't know where to start, where do you suggest that they start? What types of information do you give them?
And so first, I'm, of course, always giving them audiologic information. We do a hearing test during the appointment to make sure that there is nothing in the peripheral or central auditory system that would further contribute to reduced sound sensitivity in any form, and that includes hyperacusis or tinnitus. And so audiologically, that's always my starting point. And then from there, I do refer them on. I know Duke has a tremendous resource body for misophonia. I will refer them oftentimes to Dr. Brout, because I find that a lot of, clinically, a lot of people are in need of additional support beyond audiologic support. So those are kind of my 2 starting points. And I do offer to anybody that is interested the MisoMatch website, because I know that it is also important for especially, younger people, younger children, to perhaps have somebody age-related, peer-related that they can connect to, assuming that's okay for their parents as well. So I try to not give too much information where it's overwhelming, but enough that they feel really confident and with a lot of clarity leaving the appointment.
That's great. And Dr. Simner, back to the research side of things, where do you see, what is the most important information that we need now in order to move forward? Where do you see, our greatest needs in terms of the research?
Yeah, it's a good question. I thought you were going to say, what is the most important question, full stop? And I know that the question that I'm asked most often by parents is, how can I make this experience better? What kind of clinical support? So therapeutic approaches are really, really important. I think we also need to know exactly what type of support children would like in schools, what can help them in schools. I think we need a program of impact so that teachers have the knowledge and the information that they need to support children with misophonia. I think one of the questions that Zach asked earlier, we need to understand how much the anxiety and depression plays a role in these negative experiences of the children. Yeah, and then we could go right the way back into early childhood. When is it first emerging? Are they restless toddlers? You know, are there differences as newborns in feeding behavior and so on? So I think there's a whole spectrum of information that we would like to have. And, you know, I'm feeling optimistic that we're on that road.
There is a question. I'll ask the question in the chat before I turn it back over to you, Dr. Brout. In child therapy, what can exacerbate symptoms of misophonia?
Diana, do you want to take that? Is there anything from the audiological perspective that you think could exacerbate misophonia symptoms in children, or that you've seen in your office?
I'm just going back to the question. I mean, so in terms of other possible diagnoses, you know, if there is any co-occurrence with, for example, autism spectrum disorder, there can be definitely an overlap there in terms of how the sensory system is processing sound, and in terms of the central auditory system in response to sound, and therefore the emotional response to sound. That's so definitely co-occurrence with other conditions can be a factor as well. And so that's really what I would say in the clinic, clinically what I'm seeing as far as the audiologic aspect.
Thank you. Dr. Simner, how would you suggest helping a child who also has autism? And talk therapy isn't working, obviously, because for this particular person with autism, there are significant language processing delays. It's a very good question.
It is a good question. I would point to Jamie Ward's talk, because a lot of what Jamie had to tell us is how much sensory hypersensitivity across all the senses really matters. And that's true for misophonia, and that's massively true for children with autism as well. So I think one of the very most important things you can do is to not only minimize those audiological triggers, but to think about the general environment, to think about are the lights too bright? Are there smells that are too strong? Avoiding places where they could be overwhelmed in their senses. So I think as a first instance, I would suggest thinking about all of the senses and how you can minimize that overload.
Thank you. Two questions here that I'm going to read. One, I think, is for Dr. Simner and the other for Dr. Calzano. So for Dr. Simner, can you comment on the interpersonal relationships in terms of the idea that a sibling or a parent may be the person on which the trigger falls? And just as a follow-up to that, what can a family do about this?
So I really wish it was 2025, because I have a fantastic new PhD student starting soon who may be watching, and she is specifically interested in family relationships, social relationships, and about how they interact in misophonia. So my apology is that I don't have those big answers right now, but hopefully within a year or so we'll really know a lot more about it. One of the things we do know is almost slightly counterintuitive, which is that with my colleague Louisa Rinaldi, we looked at the children of the 90s cohort, and we looked at social relationships, and we were slightly expecting to see that people with misophonia had maybe a smaller network, because the smaller your network, the fewer people can give you trigger sounds. You know, it would be logical. We actually found the opposite. We found a significantly larger social circle in adolescents, in children with misophonia. We spent a long time puzzling over this, and we're going to explore this in a bit more depth as well. So, I mean, one early idea is that perhaps it could be two things. It could be that children with misophonia may be showing outward signs of distress, and so for that reason, there are adults responding and connecting with them, and that would be a nice thing to think. So we were looking at relationships like how many cousins are you in touch with, are you close to your grandparents, and so on, and we found that a bigger network. I mean, the other possibility is that perhaps there are more networks because maybe they're more shallow networks, that somehow you can't spend extended periods of time in the company of your cousins if they're going to make noises, but you're still a human social animal, and so you want to compensate and maybe meet more people that way. So, you know, these are just some early data points that, and some things to think about, but hopefully I'll know more. In terms of what to do, I might be tempted to hand that over because it sounds like a therapeutic idea.
Well, Dr. Calisano.
Yeah, so I mean, you know, I'm kind of reading the questions as they're coming in here too. So, you know, therapeutically, specifically for sound therapy, if I could talk about that for just a moment. You know, the whole premise of sound therapy is to help dim out the trigger. So, you know, we talk a lot about contrast relief. So if you were to light a candle in a dark room, that candle is the only light source, and therefore, of course, going to be the brightest, the first thing that your eye catches. But then if you turn the lights on, the light of the candle dims, right? And so the candle itself did not change, but sound therapy is putting on the lights, right? So you're adding in a little bit of extra noise to help dim out the sound of the trigger. So that this is something that it is not a one size fits all. You know, we certainly need to approach every person as an individual and see what their individual needs are. But it is one option to help people function out in the real world. I hope I answered the question.
Yes, and yes, along the therapeutic lines, someone had asked, what can you do in the home in terms of sound absorption, in terms of sound layering, and a concern that this person has is, you know, how much does this cost, and can it be done practically and for not a lot of money?
Sure. I mean, anytime you have higher ceilings, a lot of windows, wood floors, those are all highly reverberant surfaces. So adding in any measure to damp the sound. So adding in rugs, you can certainly buy sound baffles off of Amazon and put them on walls to help abate the sound. You can put window coverings on to help, again, quiet any reverberation or any echo that may be resonating throughout the home. One of the harder sounds to minimize are lower bassier noises, because that does travel very well through the walls. And so that is a harder tone or a harder frequency range to quiet. But certainly anything you can do to cover windows, floors, that will help to reduce the amount of sound that enters each room.
So I'll just jump in here because I think that there's some interesting comments coming in, and going back to what you were talking about, Dr. Simner, about social circle and size. There was a comment that said the more time that this person spends with someone, the worse the triggers. And so having a variety of friends helps keep their ears on their toes. In other words, you know, perhaps maybe you can comment on that. You know, why, you know, could that be an explanation for the larger social circle size?
Yeah, I mean, that's a really smart idea. And I think we were circling around thoughts like that somehow you would need to remove yourself from just a small, intense group and spread out your, you know, your attentional awareness or your ability to interact with a larger social set. And I think that comment is really, you know, potentially hitting the nail on the head. I mean, the first thing we need to do is to replicate that in some way, to find out whether the statistics tell us that it's a real finding. But whenever you get unexpected findings, it's always good to back them up and to repeat them. And so I'm hoping we'll be able to do that in the next year or so.
Another comment, I am a child and family therapist with an occupational therapy background, and this person finds that in their practice, they utilize sensory integration and complete with a sensory profile with the child and the adolescent, the family, and also the teachers. as well. And so, they find that they collaborate, get everybody involved, collaborating with other professionals involved in the child and family care, occupational therapists also doing work. They mentioned occupational therapists also doing work with, I apologize, I lost it, with Dr. Porges' Safe and Sound protocol, along with audiologists. And so it sounds like, perhaps you might comment on, kind of utilizing all of these different resources and involving everybody in a collaborative approach to addressing misophonia.
I'll jump in here. I mean, I personally have not used the Safe and Sound protocol, but I think it's tremendously important to be part of a team when helping somebody who has misophonia, whether it's academically, professionally. I think the more providers, the more researchers, the more people they have on their team, the better they are able to navigate. So I can't speak specifically to the Safe and Sound protocol. I'd actually be curious to know what anybody else's experience have been, but certainly the collaboration is a tremendous part of this.
And maybe if I can add to that, that interdisciplinary collaboration is it produces really unexpected things that you had not even dreamed of, because we're all working in our own sphere. We're all working in our own sphere. We know what we know, but we don't know what we don't know. And, just as an example, I've struck up a recent collaboration with a fantastic colleague here at Sussex, and he is an engineer. He is a physicist, and there's nothing he doesn't know about sound. And he has opened my eyes to all kinds of possibilities. So one thing that he creates physical objects that bend sound, that make sound move in different ways or cut out certain sounds. So he can create a wall, and when sound goes through it, the sound bends around the outside of the room, and there's a pocket of silence in the middle. And, just the ideas, the potential of working with him, can he create headphones that will knock out eating sounds, but let people hear? All of these. This is very speculative. This is very future thinking, but I think we need to know that there are exciting things in the future when we are open to collaborations. And yeah, his name's Professor Gianluca Mamoli, and he blows me away. Yeah.
I think speaking about collaborations is extremely important. And Lauren, if you wouldn't mind maybe talking a little bit about how your work in fostering collaborations is going to help move us forward. I think that would be a great thing to do as well here.
Yeah, I would love to talk about that. Thank you, Dr. Brout. So, we at the Misophonia Research Fund as well support everything that's being said here about the importance of collaboration, and not only collaboration amongst researchers. So, multidisciplinary researchers with different types of expertise, but all fitting together like pieces of a puzzle to advance science. And so we really believe in that. Our research, calls for research. So the research that we fund heavily supports that. We also strongly believe in the collaboration between researchers and individuals in the misophonia community itself. And so we really think that having that voice is so important, and having bidirectional communication, which is something that Dr. Rosenthal mentioned earlier, is also so important in informing, our researchers in terms of, what is important, as well as getting individuals in the community, in the misophonia community, getting events like this, getting the knowledge of what the research that's happening, getting it back out there. And so, we are implementing some initiatives within the Misophonia Research Fund, which incorporates that voice of individuals with misophonia, or those in the misophonia community, at an ever-increasing level in terms of advising the research that we fund at many different levels. And so I'm really excited to see, events like this and have conversations with individuals who are in the misophonia community, because it's just so important to have that type of collaboration so that we can learn from each other and, in order to accelerate research. And I know that that's something that, Dr. Brout and Dr. Rosenthal and and Chris Edwards, all believe in. in terms of the work that you're doing individually in your own groups. And so thank you for that question. I'm really looking forward to increased collaboration and communication moving forward. And you actually bring up something that I wanted to talk about, which was, perhaps Dr. Simner or Dr. Calzano, you might talk about how you encourage collaboration between the individuals with misophonia and researchers as well. And maybe Dr. Simner, that's a good question for you. But how can people get involved if they want to?
Yeah,
we have about 4 minutes, by the way. Sorry.
Say that again, Chris.
We have 4 minutes left, but I'll go ahead and answer the question.
Okay. I'll quickly answer that, and just to say, I'm so glad you asked about the collaborations with the misophonia community, because if it were not for... So right now in the UK, we've got a new nationwide policy to support the 60,000 children who take national examinations every year who have misophonia. We would not have that new nationwide policy if a parent had not reached out to me. One parent reached out and told me the problem. Another parent reached out within the same few weeks and told me the same problem. A third reached out, and that was enough. That was enough. That was motivation to go ahead and talk to the body. And now we have that new policy, thanks to the parents who know that their children deserve better.
Thank you. And I guess one question that I think goes to Dr. Calzano, and I guess it's a question of threshold. So I believe a clinician has asked, do you have clients who report and are able to hear outside the normal thresholds of hearing? So in other words, kids who can hear 3 rooms away. And what could you say about that? I know that I certainly have experienced this and know a lot of kids who have, and it's not something that they are making up, but literally, there is something about the way the auditory processing is working for people with misophonia. And maybe you could just quickly speak to that.
Sure. Can everyone still hear me okay?
Yeah.
Okay. So there's a couple of things. Kids definitely have or can have kind of sub-threshold, sub-zero thresholds. So, anytime audiologically we are testing, we test a range. And so a lot of times children will be able to detect different frequencies at -5, -10 decibels, which is quite soft and usually inaudible to people that are, even in their early 20s, just based off of the way that the hearing mechanism works. And there was a question earlier in the chat about any co-occurrence of being a musician and having misophonia. Typically we know that musicians have a very heightened and finely tuned sensory system. And so the way in which their brains are processing sound are also vastly different than what's considered the non-musician. And so there does tend to be this kind of range of what kids can hear and what they can detect versus what even, a younger adult might detect.
Really interesting. Thank you. I just want to thank everybody, and we have 30 more seconds, so I think we'll just end a little bit early. But again, thank you to everybody. And I think this has been a great discussion, and we could go on and talk about many different things having to do with parents, families, and children.
Agreed. Thank you very much, Dr. Calzano, Dr. Simner, for your conversation today. Looking forward to the future, with hope in terms of what we understand about children and misophonia and our ability to treat it.
Thank you.
Thanks, everybody. This has been a fantastic conversation. We're going to take a 1-hour break, and we'll see you all back in an hour. This is wonderful. Thanks for your help.